Welcome to the AAPCC SPI Best Practices Symposium. I'm Hugh Rawls. I'm from the Jacksonville, Florida Poison Center. It should be a nice, informative evening with you. We've got a nice panel tonight, minus one who's on their way. Our first person to speak is going to be Grant Lackey, and Grant is from the California Poison Center in Sacramento. He has a Bachelor of Arts, Bachelor of Science in Business, Finance, and Economics. He got his PharmD from UCSF, and he's a toxicology management specialist with, as I said, the California Poison Center there in Sacramento. He's also an assistant professor of pharmacy. He's an associate professor of medicine at the University of California Davis School of Medicine. He's an associate professor of pharmacy at California North State College Pharmacy. He's the director of residency and fellowship programs and the president of the California Society of Health System Pharmacists. So with that, I'll turn you over to Grant.
Thank you. Yeah, I think about how much I do, and it's like, no wonder my wife wants to divorce me, but she hasn't done that quite yet, so I guess I'm okay. I'm taking this from a different approach, and I tried to follow all the guidelines that they set up in relationship to what we needed to cover during this presentation. And the only thing that I'm hoping for is I don't get pounded with a bunch of questions from Mark Winter sitting in the front here, because I know how Mark gets. So anyway, moving on. I'm blessed to be at the California Poison Control Center. We're a huge system, and we're at a lot of places, and since some of you aren't from California, I thought I'd spend just a few seconds and talk about some California items. Anytime, any place is certainly one of our slogans at the California Poison Center. California's climate, highest recorded temperature, 134 degrees, part of the state. That's really down in Death Valley, so we deal with all kinds of exposures and animals and snakes in that climate. Our lowest is minus 45, and that's in Boca, California, which isn't too far out of Truckee, up near Reno. So it gets really cold, too. Average temperature is, God, just a perfect place to live, California. Total population, we have about 37 million people in our state. Mean age, 35 years old. I don't need to read all this to you, but quite a diverse population. And I grew up in San Francisco where, again, very, very diverse population. We had every nationality you could imagine. So we deal with a lot. So for decades, for many, many years, the California Poison Control Center, it was called the Regional Poison Control Center. There were many centers throughout the state, San Francisco, Sacramento, San Jose, Irvine, Riverside, San Diego. There were so many centers, and they were all going broke. They're all having all kinds of trouble. Financially, staffing-wise, it was quite a situation, but they all did a good job. And now, it was about 1997, we had a new system that was developed. One of our smartest managing directors in the San Francisco Poison Center, Tom Kearney, it was really his brainchild to put all these services together and have it be a poison control system. And he did that with the help of University of California, and they developed the University of California Poison Control System. And it's a set of 4 centers. And those 4 centers certainly cover the whole geographic area. It's a single fiscal entity, I need to mention. The central administrative office is in San Francisco, at the University of California, San Francisco. There's call sites. They have one in San Francisco, at San Francisco General, which I'm going to go through each one of these, San Diego, Fresno, and Sacramento. It's a virtual call center. All of the calls we can handle at that virtual center. We have computer programming we'll talk a little bit more about in a few minutes. Toll-free numbers with queue calling. We have 54-inch television screens I'll talk about. It's a phenomenal system that many of you might know him. Terry Carlson put together, who runs the WeBeMe software, the Visual Dot Lab. It's all connected by LANs and WANs and stuff that I don't even understand, but we'll get there. But we have same policies and guidelines. California Poison Control Center, beautiful place. It's the Laurel Heights campus, and Laurel Heights is an old, used to be Farmers Insurance Company building, and before University of California bought it, and there's many administrative buildings there. But you can see the great view of the Golden Gate Bridge in the bay, and it's just a wonderful place. Great place to be associated with. Executive Director, who runs the entire program, Stu Hurd. We have a Director of Business Operations, a Director of Program Development, Administrative Assistants, Analysts, and a Project Manager. So it's quite a system, but to keep 4 centers together and operating, it really takes this much effort. The San Francisco Division is located at San Francisco General Hospital. Fresno Madera Division is located at the Children's Hospital in Madera. San Diego is at the University of California, San Diego as well, and the Sacramento Division, sort of where I am, is at the University of California in Davis, based in Sacramento. The medical centers in Sacramento. As you can see, California is a large state. My center handles everything in green. This was based on population data. San Francisco Poison Center handles everything in blue. The Madera Fresno handles everything in yellow, and San Diego handles everything in red. But as you can see, if you look at the way at the top right side, Modoc County has a very small population, just as Inyo County for San Diego. So even though geographically it looks bizarre, it's really based on population statistics. San Francisco General Hospital, where the Poison Center is, they're actually in a home not far from this in administrative offices, but it's a gorgeous hospital. Huge, large patient database. You can see this is where, I don't have a pointer, San Francisco General is. So right in the heart of the city. You can see the Bay Bridge there. They have quite a view in some of their offices as well. San Francisco Division, San Francisco General Hospital. Oh, cool. Very good, thank you. All right, I can pick out people now in the audience. Now, if you were in one of my classes, I'd make all of you in the back move up to the front, but should we do that? No, okay, I won't. Right. Managing Director is Tom Kearney. Like I said, Tom was one of the people that really initiated this entire program. Medical Director is Ken Olson. Assistant Medical Directors, they have 4. I didn't think I needed to list all of them. A wonderful Operations Manager, Patty Hyatt. I thought I saw Patty in the audience. Patty, thanks for coming. Toxicology Management Specialists, we have 2 FD PharmDs. I don't need to read all this to you. Poison Providers. Quite a staff just in San Francisco alone. We do a lot of teaching. There's 5 fellows there and actually a pharmacy toxicology resident as well. And one of the coolest things being associated with San Francisco Poison Center is Ken Olson certainly publishes this book on poisoning and drug overdose. And all of the chapters are written, he's the editor, all of the chapters are written by poison specialists that work in the various centers in California and physicians as well. So it's a pretty neat opportunity. We have the Children's Hospital in Madera, and I had to put this in because I love the tennis shoes on the giraffe. So. Yeah, a clever, beautiful picture. Madera, we have a great guy there, Rick Geller. He also acts as the managing director, not just the medical director. We have 10 FTE PharmDs, poison providers, which are technicians that we've trained in order to do the initial calls. Many of your centers have poison providers, I'm sure. Administrative assistant, and the most important thing is the data systems and analyst. That's Terry Carlson. Now we have the data systems analyst in Fresno with the main server there because if there's any disasters or problems, Fresno doesn't have earthquakes or floods or snow or anything, so it's a very secure place. As well as Terry has an assistant data systems analyst, Tom Sands. He's listed here, but he's actually out of my center in Sacramento. We have the next center at UC San Diego Medical Center. And again, they have a great view. I'm jealous because our Sacramento center doesn't. And there's the Coronado Bridge and the Great Bay, and very nice center as well. Their managing director is Lee Cantrell. Rick Clark's our MD. Rick has been very valuable in many of the CROFAB studies and certainly our big change with anticoagulants, decon. He published a great article that changed a lot of the way we manage that about 5 years ago, maybe 10. A number of specialists, they have fellows there, do a lot of teaching there, and Cyrus Rangan certainly is there as well. He's the assistant medical director, kind of overlooks Los Angeles and Orange County. And then, of course, where I am, Sacramento, University of California, Davis in Sacramento. We have a children's hospital there. We have Shriners next door to us as well. So we get a lot of calls from those people. Here's a overhead view taken by our medical director, Dr. Timothy Albertson. Dr. Albertson is also a general in the National Guard. I think he's retiring this year, and he was on one of his medical missions and snapped a picture of the Med Center. This is the Med Center here. It's become huge, outlined there. And the Poison Center is in this orange building right here. And let's see, Shriners Hospital right here, Cancer Center, research centers, ambulatory care clinics, the main hospital, of course. And so it's a huge, huge facility. So a lot of our hospital stuff comes from within. So actually our center, we go on rounds and do a lot of teaching there as well. So we have Judy Alsop. I don't know if Judy's here today. Probably not. Tim Albertson, I mentioned. Mark Sutter is our assistant medical director, associate medical director. And we have 10 specialists, 4 providers that are very helpful, 1 toxicology fellowship. So this is the old UC Davis, UCDMC Regional Poison Control Center before we went to a system. And unfortunately, fortunately, I kind of like it. It's the sign's still there. We haven't changed it. Here's Judy Alsop, our managing director, in her office. Give you a flavor, so if you see Judy in the hall, say hi. Here's our medical director, Tim Albertson, General Albertson, and part of our center. I didn't want to bore you with a bunch of pictures of center, so. We do over 315,000 cases annually, about 900 calls a day. Our technology is very interesting. I'm going to show you a few slides. I don't expect you to know it. I did it here just for interest. We use Visual Dot Lab, Terry Carlson's development, of course, Micromedics, Poisondex, DrugDex, and we have a multitude of intranet and also internet applications from our own protocols to journals that we can look up. The most interesting thing is our phone system technology. We use telephony, NACR, and an AT&T internet connection. So what's this do for us? It controls. We control all the calls. Call overflows, direct access to caller IDs when they come in. You know, you guys are specialists. You've answered the phone. They don't give you the telephone number. Well, we can get most all telephone numbers that aren't blocked. Screen pop-ups of existing cases. So if they call again, we put their phone number in, and it'll pop up all the other cases that they may have called over the past year. Single virtual center. So let's say the system fails. We have 4 systems. The mainframe fails. Each center then can work as its individual own center as a backup. We record all the calls. Every call is tagged to that case. So at any minute, I can go and look, hit a button, and I can listen to that call, what happened, where, when, and how. Immediately, instantaneously. Integrates all calls. Automatic call distribution. So depending upon who has taken the most number of calls, they won't get the next call. It'll go to whoever has not been busy in the system. Pretty amazing. Real-time phone presence. It cross-references the case management data with the telephony data. So every one of our cases and the software is cross-connected to the telephone. It also does surge capacity voice recording on the fly. So every call is recorded instantaneously. So we have access. It allows us to increase the remote agents and let them have ability to do that. Am I getting an echo? Sorry. As well as it's all CPCS account driven. So calls can be delivered to any phone at any time. I could start taking calls on my cell phone. They could direct it to my cell phone. It's all voice over internet protocol. So unless the internet goes down, we have both types of calling with AT&T. Any questions at this point? Now I'm going to really blow you away, and I don't expect you to know this. This gives you a feeling for the MPLS data, how complicated this is. And again, Terry Carlson's the genius at this and worked all this out. I don't expect you to know that. I'm going to flash another one. This is our AVPN data line where you can see Madera, Laurel Heights, San Diego, Sacramento, San Francisco, and how they all connected back in. So they go back and forth the data. So at any one time, Sacramento can see what is happening in Madera. Madera can see what's happening in San Diego. Very, very complicated. I don't understand a third of it. And one more on how NACR worked with recording the calls. But more so, this is the easy way. This is really what to know about it. The mainframe, again, is in Madera. We're connected with each other through all these specialty lines that I already talked about, and then with the main office at Laurel Heights campus. So Patty can pick up a computer in San Francisco, and she can say, what the heck is Grant been doing in Sacramento, and listen to my calls and do whatever she needs. Correct, Patty? So it's pretty amazing. Or our boss, Stu Hurd, can look at it and say, what's Grant been doing for the last 2 hours? Or somebody called and complained. Let me go back and see what he said. And it's instantaneous. It's pretty amazing. But this is the easy way to look at it. Real-time computer data system, and I don't think anybody else in the country has this. So there is the complicated Madera equipment. Again, it's based in Madera for urgency issues if there's a natural disaster. Power supply, there's Terry Carlson. I had to put this picture in there because I thought Terry would be here. And we have a 1,500-pound lead battery cabinets and a dedicated separate diesel system for electronic backup. So if the state goes down, we're still operating. There's a little bit more of the equipment from all the different types of e-servers, vents, contact storage recorders. It's very complicated, just to give you a flavor. And of course, this is in the Madera Center, which has the real central brain of the system. And then of course, Sacramento. Now, every center has a remote site like this, besides Madera. San Francisco has one, Sacramento has one, San Diego has one. This keeps what we do in our center and allows us to be a backup if the system goes down. We can still operate as an independent center. So I hope that's not too much information on how we use it and why. So what it does is area code routing, ADC routing calls, data networking. If the data network goes down, I already talked about specific numbers for priority handling for 911. The answering tree, public exposures come first, drug IDs, nurse advice, and then other calls. And I won't bore you with this. So again, I talked about caller IDs blocked. We can still pull that up with a touch phone number, so we can dial it in. All agent calls are recorded regardless of the remote site. All recordings are tagged, so we can nail it. Office live communication, we have instant messenger between everybody. So if I'm wondering, hey, what happened with this call, somebody in San Diego, or where are you? I can instant message them immediately and get a response back. And certainly inbound caller ID we already talked about. Each center has a 54-inch television screen that looks just like this. And we have .lab follow-up statistics. So these are how many, for instance, Kathy Marquardt, she had done 13 follow-up calls. So at any one time, we can see what everybody's doing in each center. And here's Molly's been on for, on her ACD available for 2 minutes, 50 seconds. Ray Ho has been on for 55 seconds available. This person's been a walk away, maybe it's a student, so they're on auxiliary, and this student's for 42 minutes. So we can look and see what's going on and how many calls are in the queue, who's available and what. So it's very much like a insurance company call center. On the other side of this, we have .lab case start. So how many new cases were started since the beginning of their shift, gives the time as well as the number of cases they've taken. And of course, I don't know how many of you know Kathy Marquardt, but she's always out in front, see? Villano, Steve Villano is a technician, a PIP, and we can see where each one of the, when they were available at this time, when they took this picture. But this is a constantly rotating screen, constantly rotating system. It's pretty neat. And each center, again, has these, so they can see what they're doing. I wanted to talk a little bit about telenetworking. We have the capabilities currently, and we're currently testing the functionality. We have one specialist right now that had broke their foot and has been working from home. But again, the management's really evaluating the success to see if this works and to see what direction we want to take this in, more for emergency issues. I know I've been to some of the other centers like Rocky Mountain, and certainly they have snow and issues that prevents them from always coming into work, and so, you know, telenetworking is really important to them. And we're not so much that way. Certainly, some of the centers like San Francisco, the traffic can be so bad, so it would be valuable to let them, you know, telenetwork in at least a day or two a week. But we do have the capabilities and just not quite using it yet. I'll talk a little bit about the health education stuff that we do. We have a great health educator, Ayanna. Ayanna works on this, and I'll get into a little bit more what we're doing and how we're doing it. We use a consumer-focused approach. They're doing quantitative research all the time at focus groups, comprehensive statewide approach where they're always looking at various areas from Los Angeles to Sacramento to the Bay Area, for instance, or Northern California. They collaborate with state, county, local agencies, as well as professional organizations like California Society of Health Systems Pharmacist. I happen to be president. Health education materials for the public, where I'll talk about a little bit more. And of course, I spoke about Ayanna, the director of the program development. Works very hard. We have a website. The website has all kinds of special services on it. If you guys get a minute, go to the website. I'm very proud of it. Tips on your cell phone to where they'll automatically send to your cell phone, very tips about poisonings and home safety. We have a toxicology for healthcare professionals on there for physicians as well as pharmacists and nurses to go on and learn and do some online toxicology courses. 24-hour interpreter services, which I'm sure most centers have, with over 100 languages. We're on hazmat. California Public Health and Pesticide Surveillance. I'll talk a little more about that in a minute in detail. Facebook, Twitter, toll-free lines for public and medical consultation, as well as 911, and a public education line. So they're doing a lot in the form of program development. I'm very proud of our system and what we've done so far. CPCS program development, this is an amazing thing. Again, we have such a wide, diverse population that it's important we can communicate with all these various languages. So far, these are the languages we actually have written material, and you can access this online, which is Spanish, Chinese, Mandarin, Cantonese, Vietnamese, Russian, Korean, American, or pardon me, Armenian. I can't read my own slide. Japanese, and Hmong. So it's pretty awesome. CPCS program development as well. We have an antidote chart that's available online, as well as something I'm very proud of is poisoning and drug overdose. I've got a few chapters which I've been blessed from, again, Ken Olson, allowing us to participate in that. Another interesting thing that we do, and I mentioned it earlier, with the Department of Pesticide Regulation. So California, it's a requirement that if anybody is exposed to a pesticide and shows up to an emergency room with symptoms, it has to be reported to the state. We have a capture system to do that. So if the physician calls us up, the only requirement we have is to get a contact number for that patient. Then all of that information is downloaded into a system that's reported to the state. We started that in about 2006. It helps our funding. We utilize 89 counties actually use us, 69 local public health officers use us. And again, they get daily notification of the pesticides and the exposures that people have had, everything from decon to bleach to you name it, large exposures. Any questions? I'm amazing you guys, I guess. Administration and staff. We have grand rounds. Monthly, we have case presentations of interesting cases. It includes the fellows as well as the physicians, as well as many of the pharmacists that can get off the phones. Medical directors have conferences discussing cases. We get the transcripts of these so we can read them as specialists. The directors have teleconferences, and that information is disseminated down to all the specialists as well as student presentations about a lot of new drugs, a lot of new toxicities that may come out. We have a huge teaching program. We have a research committee. We have a chair of the committee. Kathy Marquardt happens to be the chair right now, if many of you know Kathy. She's a ABAT as well as a toxicology management specialist. There's members, we have one or two managing directors, and then a number of just spies. Each center gets IRB approval at their division host. So if I wanted to do a study, I have one on pregabalin right now. poster I'm presenting, I had to get an IRB approval and go through all the steps through UC Davis. We use the CPCS case database, so we put a request in to Terry, and Terry will then look for those types of exposures throughout the entire state and blind the patient's name and give us all the pertinent data and information. The results are disseminated local, state, national, international meetings, and certainly all of these are peer-reviewed usually before we're allowed to use that information. Questions? Protocols. We have a lot. We have a tremendous amount, and the question is, does it really help? Does it really identify any differences? And I think it does. We'd like to do a study regarding this, but I think it causes less send-ins, having very specific protocols that we go by on managing patient cares, and certainly our poison information specialists and our PIPs certainly have to follow these protocols as well, and I think it gives better care. As an example, you probably can't read much. This is a provider, our PIP, our technicians, the types of things that they can handle, just to give you an example. These are a few. Our protocols are huge. Again, they're physician and pharmacist-driven protocols. These are for the technicians, and you can see how simple it can be. They come in and kid got exposed to A&D, we all know it's non-toxic, but if you're new and a technician, you may not. You verify if there's benzocaine, and most of the protocols are very similar to this. Acetaminophen, what to do and how to calculate. If they have something that's outside of the limits, they refer it to a specialist. Acetone, now these are just, I got the first few. This is A through Z, and there's got to be 300, probably at least, protocols of various exposures. The pharmacists and nurses also have physician-driven protocols. So at what levels we have sending guidelines. Most of this is taken from databases like Poisondex, and the literature has been reviewed by our medical director, and then we've narrowed it down into manageable bits so we can certainly improve patient care. So a few differences. One of our criteria in our objectives is to talk about a few differences. I identified 3 that I think are differences between our centers, as mushrooms, which I was asked to speak about, as well as rattlesnake bites, and certainly black widow and venomation. So, you know, they're all sent in, and you guys probably have a lot of the exact same guidelines. So if the patient's significantly symptomatic and had a history of exposure, we send them in. Self-harm gesture. Personally, I'm going to kill myself and take a bunch of Amanita mushrooms, and of course we're going to send that in. Children or adults accidentally ingesting mushrooms where the description and location suggests a potential for toxicity. So maybe they're starting to have nausea and vomiting, and they admit, oh yeah, I was out foraging in the foothills of Napa Sonoma having some wine and thought I'd eat a few of the mushrooms. So, and now they're having symptoms. So of course those would go in. There's a twist to this though. So what we do, asymptomatic patient, we determine the history of the ingestion. When, who, what, how, where. Location, lawn, not associated with trees. And this is a huge difference from what we did 5 years ago. 5 years ago, kid got a mushroom, send him in, charcoal. Why even try to evaluate it? Didn't have the time. Growing on rotting wood or wood chips, certainly could be a Galleria or monomethyl hydrolysine or a corpine mushroom. Growing near oak or pine trees, cyclopeptides, et cetera, et cetera. If they're growing on manure in a fertilized area, then certainly indoles, and we may send some of those in, most likely would. Appearance of the mushroom, very, very difficult. You guys have been through this, I'm certain. Color green, white, brown, warts present or absent, shaped like a brain, death ring, death cap, small brown, slender steak, tall green, inky substance under cap, Amanita-containing mushrooms, white, yellow gills, might be helpful in deciding whether to send a child in, but there's a complication to this. And you guys have all done this, I'm sure, if you've been on the phones. Is it realistic? What do you think? In Northern California, we have all types of poisonous mushrooms. You name it, we got it. Southern California, not much. Guys in San Diego go, we have no poisonous mushrooms, unless, you happen to find somebody that's been on the coast picking, and you can certainly see that the amanita currently can grow in association with those coastal oak trees. So how do you define it? And the difference really depends upon the specialist. Some specialists ask all the questions to determine all these answers, and I try. Some ask a few questions, and if mom really doesn't have any clue, just send them in. That's probably more realistic. Most of the moms that I talk to, or dads for that matter, go, I have no idea. I was out there near the tree somewhere, I don't remember what it looks like. And you have to have a mushroom that's not all chewed up and masticated and swallowed and spit out so you can try to identify it. That's pretty rare. Some of our specialists, they give up. They don't even want to quiz the mom and just send everybody in for charcoal and to watch, observe. I must admit, I have been doing this for, gosh, I hate to admit it, I'll say over 20 years. That's not as bad as. And I have never seen a kid that took an accidental ingestion of a mushroom become toxic. Never, not once. Now, I've seen people like Paul Sebastiani from the wine family, Sebastiani wine family, who was out foraging, having a great time, drinking his dad's wine, partying, just having a wonderful time, and died. He didn't present to the emergency room for about 2 days. He had nausea and vomiting and thought he had the flu. And he had liver failure and passed away. So you can see I'm starting to believe more of watching kids at home and really defining, is that a lawn mushroom and how seriously toxic is it? But again, this is really left up to the specialist, how they interpret the mom, how they interpret the phone call. So again, let me point out, I defend some of those specialists that send all kids in. Great guidelines, we have great guidelines, but no one has ever been incorrect for sending a child in for evaluation in charcoal. That's a reasonable solution. Holy smokes. What's that, a spider? No, it's a lizard. I'd run if I saw that. Of course, you guys probably from other parts of the country have a lot more snakes than we do. We get our fair share, and you guys know how to treat it. We have 4 centers in the state of California. Each medical director has a little bit different take on how they treat it, certainly, and then, of course, each specialist in our center is allowed to either accept the medical director's suggestion or follow the manufacturer's guidelines. And 4 to 6 vials initially, of course, with CroFab, may repeat until control of symptoms, swelling, lab changes. And then the manufacturer recommends 2 vials every 6 hours for 3 doses. And we don't do that. We don't always do that anyway. We watch the person. If swelling stopped after the initial loading dose of the CroFab, and the platelets are above 100,000, fibrinogen above 100, we'll stop and just watch. Now there's various articles you can read about this, whether the antivenom starts to come out of the tissues and cause more toxicity or not, but it seems to be working for our center. The difference is we will not change the recommendations of another center. So if I get a follow-up call from a San Diego hospital, I'll refer it back to San Diego. I won't say, oh, no. We don't give the Q6 hours times 3 doses. We've stopped. So that's kind of some of the differences we have with the North American. Well, then we think about the Mojave rattlesnake. We don't have a lot of experience in Sacramento with that, so we'll refer that back to San Diego, where they have more experience with the neurotoxins that happen with the Mojave. So again, it's working together. Even though we have 4 systems with 4 specific protocols, we still adapt to that. And a lot of it's just common sense as a specialist. Black widow spiders. So muscle cramps, spasms, you guys all know this, treated with opioids and analgesics, muscle relaxants. Of course, calcium has been relatively thrown out the window now. We used to give calcium years ago. For hypertension, of course, the nitroprusside. But the antivenom is a big issue. We have a group of physicians at Kaiser hospitals that swear on antivenom. They say they give it, symptoms are gone in 2 hours, decreases length of stay, better overall picture, better care. Our medical directors, on the other hand, say, well, you know, there's risks. There's anaphylactic risks, serum sickness risks, and other risks associated with this. Let's watch the patient. Let's try to just treat it with opioids, analgesics, or muscle relaxants. And so this has become a controversy within our own center, not only that, but other centers as well in our state system. So that's to be resolved, but it's interesting. And we get a good share of black widow envenomations. Any questions?
Y'all still in the basement?
Yeah, no. 4th floor, please. So, of course, this reminds me, when I saw this cartoon, it reminds me of, as you guys know, 80%, at least in California, 80% of our rattlesnake bites are young white males between the ages of 18 and 24, and there's always alcohol involved. And usually they have more than one envenomation. They're bitten, they pick it up and get bitten again. And so that's what this guy reminded me of. Anyway.
We should test the serum for the venom of the snake.
What's that?
Maybe we should test the venom of the snake problem.
There you go, exactly. See if this works. But anyway, thank you very much. I appreciate it.
Any questions for Grant before he's done?
And I'm around. Come and see me.
He's around. Come and see him. Pass the pointer back there, Grant.
Oh, I'm sorry.
That's all right. Paul may want it. He may not want it. I don't
Taking
know.
this.
Okay.
It's the biggest pointer I've ever seen.
I promise I won't point at you.
Our next speaker is Mr. Paul Starr. He received his Bachelor of Science in Psychology, Pharmacy, as well as his PharmD at the University of Maryland. He's a diplomat of the American Board of Applied Toxicology. He's been a poison information specialist at the Maryland Poison Center for 23 years. He has served on a number of AAPCC committees, including chairing the SPI committee, and he's continually worked towards participation of the SPIs in the toxicology community. And without further ado, I will give you Mr. Paul Starr.
Oh, I have to get rid of his thing.
That I can't help you with. Which one's yours down here? Is it yours down here? Is it yours?
Yeah. Yep. Oh, we have to get him down. Escape.
Escape. There you go.
Oh, and then.
There you go.
Okay, good. When this is all said and done with, I want you to remember two things. We're only one center, and we have a 65-inch screen television. Let's see, which one, how do I go down here? This one?
Use the down button here.
Okay.
Well, I'm still trying to figure out how to watch football on ours, but it doesn't work.
Oh, by the way, Irene knocked ours out. We can't get the football games anymore. I work for the Maryland Poison Center, as it's been said, but we are a single poison center. And a lot of what I'm going to say, or was going to say, is kind of redundant in terms of phone systems and so forth. I think, for the most part, all poison centers are progressing in their technology to the point where we're all recording. But for now, I'm just going to let you know about our beginnings. And our beginnings started in 1972. So at this point, I can still say we're 39 and still counting. So next year we'll be 40. And at that time, we started out in the basement of the Dunning Hall, which was the Maryland School of Pharmacy, complete with the dampness. And we had a notorious 4x4 wooden, what we called roach killer, because we had roaches there that would probably carry you away in the middle of the night. We had about 5,700 calls a year, but at that time they were answered by pharmacy students. And that's a good thing too, because we needed the young guys to read the 3x5 index cards. And then, of course, as technology started its ascent, we had the microfiche. And for those who don't know what the microfiche is, that's a microfiche. You can notice that it actually resembles the CRT monitors of yesteryear as well.
Couldn't find the slides.
So as we move on, we move to the second floor of the new pharmacy school, which is no longer the new pharmacy school. Over on the left, you'll see this is our call center consisted of one room with a counter with about 3 or 4 computers on it, shelves for the books, and on the other, there was another room that housed the original starter of the Poison Center, the visionary Dr. Gary Oderda. So, and at that time, Wendy Kleinschwartz was there, and we'll get to who she is and all. We moved on to the 7th floor of the same building. Notice it's a little bit plusher. Right now we're snooping in on grand rounds going on with some medical toxicologists. You can see the SPI in the back. It seems to be the general theme that we have the daily rounds in the area where the specialists are. And if they're not on the phone, then obviously they can participate. This is the 7th floor, so we're moving up. Still no windows, though. There are windows in administrative offices, but we had no windows. And there was one more move. And now we've moved to greater heights in this building. We're in this corner looking over the western part of Baltimore City. And I have to tell you, this is truly an incredible venue. To watch the storms come in and hit, and lightning hit these buildings and the street is amazing. There's only one glitch. For those of you from the West Coast, this may not seem important, but recently we've had an unexpected 5.9 earthquake, and when you're 12 stories up, and it starts shaking underneath your feet, you begin to question your venue. But we love it. This is garage. You can park in the garage if you park during the day, and just walk up a couple flights of steps to the center. And in addition to parking in the garage, we also have 2 spots that are right outside the building. So for those people that leave late or come in early, it's relatively safe as compared to the rest of the area. This is a picture of our main call area. Over here is the SPI cubicles. As you can see 2 of the 3 monitors, and the 2 monitors on the right are for the use of the SPI. They can have VDL up, which has already been explained, and then you can put like anything you want on the other side. We frown upon solitaire and free cell, but usually internet for access and Poisindex will be running on the opposite side. The third one is the phone system, which is also portrayed on that 65-inch monitor. Very much the same thing, but not call waiting, how many calls are in queue. We don't have voice VOI or VoIP, but we do have a very similar phone management system. And each person has that particular scene on the 3rd monitor. So again, we also know who's available. It rotates to the next available person. skips over somebody's, well, it goes aux out when you're making a call out. Aux in is when a call is coming in. And all the icons are different. It also provides us with incoming, when an incoming contract call comes in, we have private contracts, so we know when those calls are coming in as well. We do have caller ID, but it's not to the extent that Grant was speaking of with his centers. We're not exactly Mayberry, but we're somewhere between there and California. On the far wall, though, you'll see 3 computers, and that's where the students and the residents sit to listen on phones. They actually have access with the phones just by pushing an observe line, and they can listen in on any phone calls. We ask them not to push it twice because then they can be heard, and if they start laughing or something, it doesn't make for good public opinion. As well, there are a couple of cubicles on this side of the room that the students and we'll get into the programs we have for undergraduates, but they can start taking calls during their rotation, and those cubicles are over here. The student presentations and daily rounds also occur here. If we do want to, again, shoot a PowerPoint, we'll use that same monitor. We do also have another monitor just like that in this series of offices over here. And we'll get to who's back there as well. And then the administrative offices are actually down the hallway, far down the hallway, and we have quite a lot of space in this place. And it's just an amazing area to be. And to be up high like that, with windows all around is just, it's quite refreshing. So, today, instead of 5,700 calls, we're getting 60,000 calls. But instead of being manned by pharmacy students, we now are manned by pharmacists and nurses. And the nurses at our center, before they come there, have to have a minimum of 3 years critical care experience. All our pharmacists and nurses, except for really one new specialist, have at least 10, and probably more accurate, at least 15 years of dedication to the Poison Center. And for those who have long-term specialists, this accounts for a great deal of talent behind that phone. There was a time, and with a little history, the phones were manned by part-timers and also professional students. And what we found with part-timers is there wasn't near the dedication with part-timers, unless they had already been a full-time specialist. It didn't allow them the time and the commitment to really pursue it to excellence, the job to excellence. Of course, as with all information, all poison centers, the information base has changed. Everything is electronically accessed, but we still have, as everybody, hard copy text. We have we have literature support both online, through internet and network, as well as access to the internet. And then we have very, very valuable daily rounds run by our medical director, Dr. Suzanne Doyle. As far as who's in that big, nice office, well, we have 13 specialists. 10 of those specialists man the phones full-time. Then we have one quality assurance specialist who actually works to provide, an accurate, well, she kind of lines up the data coding with the record. So she makes sure our data and our written records and phone records are all in sync. We have a clinical education coordinator, also a specialist, and then also, and that's Lisa Booz. And then Angel Bivens is, in fact, our public educator, and she also is a certified specialist. Along with our managing director, Dr. Bruce Anderson, and our medical director, we also have Dr. Wendy Kleinschwartz, who is coordinator of research and education. She oversees all the research in the center. She also oversees the rotations and the actual experience by the medical residents that come through and the pharmacy residents that come through, as well as the experimental, the rotating undergraduates. Now, with all this technology, they have several different aspects of their technology, and that's all over the state. But even within one poison center, since the phone systems and the network and the intranet and so forth, it has become unbelievably nice to have a IT guru full-time. Problems can be addressed immediately, and without any kind of delay, they're really rectified. So there's really little downtime. And then, of course, last but not least, is our administrative assistant, who's actually more aptly named program manager, and her support staff. And of course, they're the glue that keeps our ship a-sail. In addition to our family, has been people that we've hired for analysis of the data, and that includes a PhD-trained statistician, and also a specialist in geographic information analysis. Now, you know, for one poison center, that's a lot of people actually for 60,000 calls. But believe it or not, it actually cuts down a lot of the labor-intensive chores, especially when it comes to data analysis. We can pick up on trends. We can geographically map our data in very little time with these expert individuals, and we can set trends, see trends, and address our target population concerns, you know, without delay. The responsibilities of the SPIs, with what they are offered and with what they are responsible for, they have to wear quite a few hats. Of course, primarily, they are there to provide triage and treatment recommendations on the phone, and that's their main function. But in addition to that, they also mentor rotating students and residents, and they also assess their capabilities to do what they're being taught. We also rotate, and this is an interesting thing, we also do self-scheduling. We rotate through the SPIs, through the specialists, an 8-week schedule, predominantly made up of 12-hour shifts. And these are long shifts for an old guy like me, but it's nice to have 3 days off one week and 4 days off the next. And it also provides for a 3-day weekend every other weekend. It also, doing your own scheduling, I believe, builds teamwork, because you have to work together to fill the holes in a schedule with vacations, planned sicknesses, you know, like an operation or something like that. And so it's almost like playing the game. You know, you give me a night, I'll give you a night. So it teaches you to be a team. I'm putting you to sleep again, aren't I? I do that. And then we also are responsible for quality assurance on a daily basis of our hospital cases as we follow up on them. And then when there's time, of course, as in many poison centers, there isn't a lot of free time. So many of these next activities have to be done on somebody else's free time. But if there's enough personnel, and some days there are as many as 4 specialists on the phones, then one can get off the phones and do what they need to do if they have a research project or if they're preparing for a public or a professional presentation. In addition, the university also requires that we also contribute or do other miscellaneous activities. And it may be something like an antidote survey of the local hospitals or participation in development of a personnel policy. And at the beginning of, once a year, we have to actually turn in our plan as to what we need to accomplish professionally. We have to have 2 professional goals. Another I guess, benefit by being associated with a university is that we are, as a teaching facility, we have a great deal of exposure to, and as a professional educator for professional students and emergency medicine residents and pharmacy residents. And these emergency medicine residents sometimes rotate through, and at some point they were actually taking calls. Pharmacy residents also rotate through for a few weeks. We also have EMS providers who are from a number of county programs as well as university programs in the area that also rotate through. And they listen to calls so they can get a good idea of what their resource is on the other side of the phone. We also have a postdoctoral pharmacy toxicology fellowship that's 2 years long. It provides a wealth of experience in research, education, and clinical experience. Many of our fellows go on to become, to have actual active careers in the field of toxicology. Our undergraduate students have three electives that are open to them. 2 didactic, the Introduction to the Poison Center, and clinical toxicology, which are primarily case-based experience teaching. And then the experiential rotation is a 5-week rotation where the students are required to first listen. They're also required to do a paper. They're also required to do a presentation on a case. And they also start to take calls their 2nd week, or actually the 3rd week. They do drug IDs, I think, the 2nd week. And then by the last week of their rotation, they're doing full-blown cases. Again, always being mentored by the SPIs that are around them. So, how do we serve the health community within our little world, our little realm? Well, first we're part of a facility resource emergency database affectionately called FRED. We're actually at FRED 2 now, which is an online-based alert system that is designed to alert first responders in the case of a crisis or a hazmat, and many times it requires a feedback system. And sometimes that may be as simple as just providing them information back. Sometimes it's just something as simple as area hospitals are full and cannot you know, or on yellow alert or something like that. But it's on all the time at the center. We have recently developed a relationship with the emergency, the medical examiners. I'll get back to the emergency medical response communications. That we're exchange of information on our cases, where we can now take their cases and see our cases and add the accuracy of our cases that ended up in mortality with their data. And we can also see trends in mortality, also seeing their cases. The emergency medical response communications is what it is, it's a SysCom, it's 911. And not all centers have this, but our center does have radio phone access where we can consult with the field paramedic as well as the receiving or consulting hospital at the same time. Many times being able to give treatment and triage recommendations prior to arrival to the ED. So we get a jump on the game. We are also currently developing a relationship, a very interactive relationship with our Department of Health and Mental Hygiene, where we have kind of a passive download of our cases to them. And this is allowing a quicker review or a more accurate review of outliers. And it also helps determine trends in our target population. In turn, the Department of Health helps us reach out to the health providers that are servicing our target population and letting them know where our concerns lie and where our needs are. In addition, our professional educator, Lisa Booz, who just walked into the room, is responsible for coordinating professional education and in-services to all walks of life in the healthcare profession. Nurses, physicians, PAs. I'm even doing dentists and oral surgeons now. We're reaching out to as many people as possible, which is the whole healthcare community, where toxicology is going to be an issue or is an issue. In addition to that, we have a small, little, concise, and informative publication called Tox Tidbits that's both, and I'll get to our online, is both online and facts to professionals and emergency rooms. And it's usually regarding either season-sensitive or trend-sensitive issues. Like this time of the year would be mushrooms, or more recently, bath salts. So we try to keep people up on what's going on in many different ways. So obviously, poison centers wear another hat. They also serve the public. So how do we serve the public? Well, these are just a few of the things that Angel Bivens does and the Poison Center does. Obviously, as all poison centers, we disseminate poison information programs and materials. We give, and the materials are available, I believe, in Spanish, but we don't have quite the extent that you have with all the different languages you have. When possible, if there's a troubling trend like bath salts, we will, and there's time, we will grant interviews to the media in hopes of providing the public with accurate information. And we are also quite active in statewide safety commissions. Angel is an active participant in the local and state chapters of like Safe Kids. And she's also beginning to spend more time and more energy with the people that are in political positions as well, as are many people in the Poison Center. And of course, in keeping in line with today's technology, we also have online access through website and Facebook, and up here, they're there for whoever wants to, mdpoison.com. And on Facebook, facebook.com, Maryland Poison Center. And as they do in California, we have an intranet, and on the intranet, we have our guidelines. And it's interesting you use the word protocol, because I just want to address that a little bit. We refer to them as guidelines, and we have big books around that also have those. And, you know, guidelines, for me, is more appropriate because there's always gray areas. That's why we have the medical specialists to consult, you know, because there are always things. And we do have some protocols, but the guidelines over time become protocols. So the technology today is, obviously I can't get into it like granted that the California system sounds unbelievable, and I wish we had that. But our phone systems, again, is a phone management type system that allows that ability to see who's coming in, how long they've been waiting, who's available, drop calls, again, the contract calls. It also gives other information, you know, and we also have, I hate to say this, but we have a buzzer that goes off if somebody's on hold for more than 2 minutes. And then a light that flashes if more than two calls are in queue. But believe it or not, you know, when I first started that system, I was like, oh man, this is going to be a pain. But you know, you sometimes get into a phone call and you don't realize you could be dead 1 minute and then have 6 calls come in the next. So it actually makes sense. We are developing, of course, the electronic medical records we have the same system, the VDL, so I'm not going to go over that. We are working currently on an automated drug identification system. Now, in the last 5 years, our drug identification has, it's quadrupled in the last 5 to 6 years. So we are developing, or in the process of trying to work out the bugs in a rather extensive phone ID system. And I think it's going to be able to identify up towards about 5,000 drugs. So that's quite extensive. Hopefully that'll be soon. Remote access, as Grant had pointed out, in our system is also used primarily for emergencies. In our area, we've had enough snowstorms to know that not everybody can get in. With the years of dedication comes aging. With aging comes health problems. With health problems comes personnel shortages. So, hence, it'd be nice to be able to call someone and say, hey, can you take call? And that person say, well, I can't get in. Can you take call from home? Yeah. So the remote system is quite useful, and there is very little functionality differences. In fact, our library has offered and, in fact, put many of our favorite tertiary references online. So not only can we access those that are in hard copy in the center, we have access to internet, we have access to our network drives and all the literature that we have on that, all those items, all the data, everything we have that's at the office, we can access at home. And every once in a while, we're asked to go ahead and go online from home, even if there's not an emergency, just to make sure that our system is updated and that it's working. So if there is an emergency, then it's there. And of course, data upload, we all deal with on a national basis. And again, we are doing it also with the health department. And this to me I think this is an amazing thing. I think the ability to see outliers, the ability to see trends before they really become major problems is an exceptional ability for poison centers to have to kind of nip problems before they become major issues. Oh, by the way, at one time, all this probably filled several rooms. This is our network and our telephone system. This is our big closet. I was supposed to have referred to this earlier, but Alzheimer's is a pain. Most of our funding comes from the University of Maryland, which in itself is great, but it's also a double-edged sword, because when there is a cut on the university, it trickles down to the poison center as well. But to help subsidize that, we have the federal grant, of course, federal grants, and we also get some monies from the State Department of Health and Mental Hygiene. We do a survey 4 times a year of our callers, and we actually ask them if they're medical assistants or not. So the Department of Health and Mental Hygiene, actually responsible for medical assistants, actually sees that, and depending on the percentage of calls, we get money from that. Other grants, research and other grants, consumer contracts, we have 3 consumer contracts, and of course our participation in radars. At this point, is there any questions with regard to the Poison Center? Yeah.
When you were talking about the postdoctoral fellowship, is that for PharmDs only or for PhDs?
PharmDs only.
And what training database do y'all use?
Visual.lab.
Thank you.
No problem. Yes.
You mentioned that you get an average of 60,000 calls a year.
Correct.
And I'm assuming that includes the drug ID calls?
Correct.
How many public, not from contracts, public exposure calls? I don't know how many are public, from the public, but I can tell you that, and this number is actually increasing over the last couple of years, but about somewhere between 15 and 20, and it's approaching more like 20% of the calls are either hospital-based or the patients are referred into the hospital. So I don't know if that gives you, it doesn't answer your question, but I don't know the exact number. I don't know if Lisa or anybody from our center knows the exact number or percentages public.
Public versus health professionals?
Yes.
I'm sorry,
She's Lisa, she's asking what percentage of the calls come directly from the public. Do we have?
Versus contract.
Okay. So about 34,000 of those are exposure calls. I'm sorry, as usual, I didn't understand. Okay, so just a couple of minutes for how we handle mushrooms. Actually,
Mushroom calls are not actually a big part of our call volume. We rarely have any serious mushroom exposures, but we do have some. And over the last 6.5 years, we've had a total of about 438 exposures. This graph is totals, and it's done by year versus amount. And this one breaks it down to actual months. And as you can see, in our case, it's a seasonal issue, and in most cases, it actually peaks around this time of the year. Now, how old are these people? Well, the top line, the pale blue, is the young is the 6 and under. So as you can see, the age 12 to 20 comprises of the second majority of our poison calls regarding mushroom exposures. So why? Why is that? So in terms of reason, it's obvious. You can just read these numbers yourself, but the majority of them are obviously unintentional. The majority of them are by toddlers, and I actually have it further broke down if you want to see it, but most of the exposures are around 2 years of age. So, and then there's 120 intentional. I don't know if any of you have heard of magic mushrooms, but I think that kind of explains it. Yes. Oh, you have? I knew that. So in some cases, there was an adverse reaction, and that can be argued because some mushroom toxicity is actually thought to be a reaction. The management site, 269 of them were treated out of the healthcare facility. 155 were treated in a healthcare facility. 8 were referred in but refused. The outcome, as you can see, the majority of them had no effect. And the mild effect, which is usually GI, is the next highest percentage with 65. The moderate effect is 45. And according to AAPCC or National Poison Center data, hallucination is deemed a moderate effect. So the most of these are magic mushroom or ibutenic mushrooms. So this is a little redundant, but the outcome versus the management site is kind of interesting to me because of those that were managed on site, here's the numbers. The majority of them, as you can see, nothing happened. En route, you can see 55% of them had minor effect. And if you remember this slide and our triage guidelines, you'll see that it all falls in line. Moderate effect is 40. That accounts for 2 reasons. People that are going to the hospital are usually symptomatic and sometimes late presenters, or they're usually intentional. So, again, this is going to be kind of a repetition of what Grant said, but when a call comes in, we try to get an adequate history to help determine which agent is involved. And we do have 5 minutes? Yeah, Grant took all my time, didn't he? Okay. That's about how long it happened. So anyway, we asked the symptoms of co-ingestions. It's very important to ask if there are co-ingestions involved. obviously, coprine and alcohol. Mushroom identification, we try to ask them to describe the mushroom. You know, I don't know that I've ever heard anybody ask if they cut the mushroom open, the little bulb on the yard, to see if it actually has gills or not, or if it's a puffball. But we do ask them. I actually have asked them to email me a picture of the mushroom. And although you really need a mycologist to do an adequate identification, at least you can rule out Amanita and some of the other poisonous species of mushrooms. And it'll make you feel better about keeping the child home or the person home. We have had a mycologist that did mushrooms. We don't have one presently, but we usually try and find one. There are mycologists around. There are mycology societies around that we try to tap if we need to. If the patient or if the person is symptomatic, or if we don't know what mushroom it is, we ask them to store the mushroom in a paper bag in the refrigerator just in case there is a development of symptoms, and so that we have that mushroom in the hopes of identifying it. So if somebody is symptomatic, this continues to be redundant, but to help provide us with more information as to the identification of the agent involved, we ask when the onset of symptoms were, the ingestion and frequency, the preparation and storage of the mushroom. And this is important because some mushrooms obviously have heat labile poisons and some aren't. And also storage, you know, some mushrooms are edible until they start breaking down. Preparation and storage, and alcohol ingestion, of course, goes into co-ingestions. The variety of the mushroom, and obviously this is always clear. And with foresters, many times you're going to get a number of mushrooms. Where, and Grant already effectively hit on that in terms of under trees, yard, so forth. The season, again, it's been covered. And then commonality of symptoms within the household that the mushroom exposure existed, especially in cases of foresting. So we take this information and we kind of plug it into this flow chart. And I can go through all this, but I only have 3 minutes now. So I'm not going to do it. But you can get the idea that this will help enable with the identification of an agent or the potential identification of an agent, and then further help mediate our recommendations as far as treatment. And I want to say this, we don't have any specific treatments for specific mushrooms. We usually follow the tertiary and the poison index literature in terms of what we recommend. But we do have some guidelines, or at least some vehicle for determining when to send in and when not to send in. Obviously, the main thing is the children, and children and little brown mushrooms are responsible for most of our calls. If we get a call for a child with a casual ingestion of a mushroom in the yard of less than 1 cap, we keep them home. We make sure to do a 6-hour and a 24-hour follow-up. Now, if the child is asymptomatic at 6 hours, we keep the child home. If the child becomes symptomatic, we send the child to the hospital. At no time do we forget to tell the parent or the guardian or whoever is responsible for the child, do we ever forget to tell them to call us should any symptoms arise. Now, on the slim chance they don't call us and the child becomes mildly symptomatic, with transient GI, a little nausea, maybe 1 or 2 episodes of vomiting, and it resolves, it occurs within 3 hours, and you know, by the time we call it 6 hours, the child is perfectly normal. I feel very comfortable leaving that child home. All unintentional misuse ingestions from adults go in if we don't know what the mushroom is. All symptomatic patients go in. And it's important to remember, going back to the other slide, that again, it's very difficult to determine which agent, because many times in mushroom exposures, there's a number of agents, or there's a number of issues that determine why that mushroom is poisonous. You know, not everybody gets poisoned by a gyre meat or mushroom. There's not all mushrooms have the same amount of toxin in them. Not all mushrooms are eaten at the same time in their life, in the life of the mushroom. So we have to be careful, and we have to be cautious. Again, all suicides, intentional exposures go in, and also recreational use. Now, recreational use, these people usually do well. They fairly do well. But on the slim chance they ate something that resembles, like maybe something with a cyclopeptide that they thought maybe was psilocybin, you know, we need to pay attention to that, because these mushrooms do look alike. Galerina is certainly not as overtly different as, you know, Amanita series species. And that concludes my presentation. Any questions?
Okay, they're going to load her presentation up real quick while I introduce her. Our next speaker is Dr. Eileen Lopez. She's a bilingual physician and a CSPI from the Georgia Poison Center. She's been a CSPI for the last 3 years. She graduated from the Universidad Central de Este in the Dominican Republic in 2003. She is also one of our SPI committee members who's been on the CSPI committee for the last year. She's AHLS, BLAST certified, and ITP trained. And I thought he would be done if I stretched it out, but obviously not.
We need to stretch it out a little longer.
Stretch it out a little bit longer. As soon as he gets it done, I'll give you Eileen here. Let her say hello first.
I am not 100% sure that your video is going to work on here.
Oh, really?
So we are going to do a quick test right now. It doesn't look like it is. It is not going to work on here. It is a Mac-based. This is a PC-based. So the video will work. Peanut gallery here. We have a little more time to work on this for you. Probably won't be able to resolve that. Right now I can't.
I think my boss has his laptop and it's in here. Is there any way we can use that?
Sorry.
No, no problem. Good afternoon. How's everyone doing? I guess I may have to kind of play and be a little bit more, kind of change it up a little bit so we won't be that redundant. I think I have a lot of things like the rest of the presenters, so maybe we'll be a little spontaneous and change it up. I'm from the Georgia Poison Center. We initially started in the basement of Hugh Spalding's, which is the pediatric facility in downtown. Dr. Brauburn, many years ago, started our poison center. And a little bit later, I'll talk to you about how many poison centers we had in Georgia at that time. Nationally, and over the last year in 2010, there's been 2.4 million exposures. In Georgia, in 2010, we've taken about 100,000 exposures. The majority of them are accidental, and probably 50% of that is little children being curious, getting into things. So I believe that, it's one of the biggest accidental injury and death in children with toxic ingestions. So what is the Georgia Poison Center? It's a poison and information emergency call center. It provides free, timely advice for 159 counties that we have in Georgia. We are a Grady entity. Grady is our facility in downtown, which is, it has been there since if I'm not incorrect, 1892. It's a level 1 trauma center, and it is internationally recognized as a teaching facility. So that's what, we're funded by the federal and state government, but our monies flow through Grady. We are under their umbrella. We follow their procedures, regulations, but we are separate from Grady. Poison Center has been in Georgia since 1976. At that time, before it actually became certified, there was about 11 little centers over the state of Georgia. It was an emergency room, it was a small little desk, and it was somebody answering the phone. I don't even think there was a nurse. It was just somebody answering the phone, giving some type of recommendation. Don't even know where they were getting their data from. So in the 70s, we were able to do some funding. I believe we had received the funding because we were asked to review the charts one by one. So there was a chart review, and we were able to be funded and certified, and that's how we became one Georgia Poison Center, and the rest of these small little locations began to close down. We're open 24 hours a day, 7 days a week, 365 days a year. No vacation for us. We're constantly functioning. We're nonprofit. About 75 to 85% of our calls are kept at home. We're able, that's the purpose of the poison centers, and I believe that would be a generalized comment for everybody. It is, we're trying to eliminate the visit to the emergency room. We're trying to eliminate that anxiety for mom, dad to sit in an emergency room with their babies when when they call us, we can determine whether it's a send-in or a leave at home. We're trying to avoid as well the, actually being exposed to a medical situation, a cold, the flu, something contagious in the emergency room. So for every $1 spent, Georgia Poison Center can save up to $16 in unnecessary health expenditures. The Georgia Poison Center mission statement. It's a provision of 24-hour-a-day prompt and accurate poison information to those accessing services. Education of Georgia residents in the areas of poison prevention and first aid. And the education of healthcare professionals in the areas of clinical toxicology, poisoning epidemiology, poisoning prevention, toxicological diagnosis, and care. the Poison Center receives between 250 to 350 calls a day. 80% are laymen, 15% are healthcare professionals, so the hospitals, and 5% come from a workplace. So somebody may be a car wash, somebody may be exposed to some type of chemical. A lab, they can be testing something and they could be exposed to that. We receive calls, obviously, as well as all of us. Human poisonings, the exposure that occurs at home. So a child gets into the Tylenol or the Motrin. Mom had given him a dose, left it there, and the baby thought it was tasty, and went ahead and self-served himself with a bottle. The occupational exposure, like I just mentioned, mechanics with antifreeze, splash of antifreeze to the face, to the eyes, to the mouth. The intentional overdoses. I was looking through one of our systems the other night with one of my coworkers because I work the night shift, and I was trying to figure out how many cases I had taken in the 3 years that I've been at the Poison Center, and apparently I was up there in 15, somewhere around the number 15,000. So it kind of breaks it down to actually what exposure you do the most. And barbiturates, hypnotic sedatives, so benzos, the Ambiens. So, you think with all the calls that I take, I thought it was snake bites. Well, it wasn't. It was the hypnotics. And I may say that since I work the night shift, maybe that's why I probably get that exposure so much. We also have the plant and the food poisonings, and the animal, the snakes, and the spider bites. In Georgia, we have the two, the black widow, the brown recluse. Those are the big spiders that we're concerned about. And we have our snakes. We have our copperhead, our timber rattler. We have a couple of snakes. We follow a very tight protocol with our snakes. We used to take care of actually animal exposures. We just cut that off. I think it was in August 1st, we stopped taking animal exposures. We would help out the animal. We were sympathetic. We all have animals. I think all of us at the Poison Center, at our center, have dogs, cats, something. But it's taking up too much of the time and effort, and we actually have calls that are, waiting in the queue that actually have to be tended to, with babies ingesting a calcium channel blocker that can't wait. At the Poison Center, we provide the phone information. We do the rabies assessment and treatment information for the state of Georgia. When there was a shortage with the vaccinations, we actually we went through it with our toxicologists, every particular case, and we would give a code word because the pharmacy would not release unless there was a higher decision from us because we work directly with the rabies with the state. Occupational and environmental tox info, information requests, pill IDs, which we are also implementing the automated pill ID system. I'm not sure when it's going to be starting, but we're also implementing that, and we get pill IDs from the officers. We have a very high volume of calls from police, from parents, from the homes. We also do information requests. Sometimes they go a little bit onto the medical side. What medications that could be mixed, what can't be mixed, just depending on, if there was not an exposure. Once there is an exposure, it then changes from info to exposure. We also have the Mass Crisis Support, which is ChemPAC. ChemPAC is it's pre-positioned antidotes in the event that we have some type of nerve agent, some type of chaos go on. Well, we have a little rehearsal for that. We do, I think it's twice a year, we do a drill, and we go over the ChemPAC and the functioning, the procedure for it. And it's we have maps set up on our screens where it could be. They actually call us to present an actual case as if something were occurring, and we go through the whole procedure. The CDC stockpile provides those antidotes. Professional education. We have. I'll go over that in a few minutes. Some of our directors give certain classes, and I'll go through that in a second. Public education, research and data collection that usually occurs at Emory. And so our staff is what works, what makes this all happen. So we have 21 specialists. 19 were almost completely certified. 19 of those are certified. 2 of them, we came in years ago where they were actually not grandfathered in because they were unable to take the SPI examination. They were unable to certify. They have degrees of science, so they were actually able to become spies, but not specialized. They are not certified, not special certified. They're not. So we have 2 that are just spies. Those are the only 2 that we have that are not certified. We have 5 foreign medical graduates that are. I think all of us are from Dominican and one's from Ross. So our schools were accepted here in the United States, are certified. There's 2 pharmacists, 9 RNs, and then the 5, we have another category of 5 people that all have degrees of science. Then we have our directors. Our medical director is Dr. Robert Geller. He's a pediatric toxicologist. He's been in the Poison Center for about over 20 years. Dr. Gaylord Lopez, which is here, he's a PharmD ABAT. He's been here as well for over 20 years. And Dr. Stephanie Hahn, PharmD, she's been there for 3 years. Her participation at the Poison Center is she does a very rigid employee training, very rigid pharmacy rotation. The training is of, it's a 6-week training, 2 weeks of extremely difficult didactics, and 4 weeks of phone training. Then we have Dr. Brent Morgan, which he is the program director. Dr. Morgan oversees the fellowship program. I believe there's usually 2 to 3 slots for the fellows. We do MD fellows and also pharmacy fellows. Dr. Morgan has 20 years of emergency room medicine experience, and he's been with us at the Georgia Poison Center for 15 years. Our tox program that he oversees it's a 2-year program, first and second year. And he also started an international fellow program. So we have some Middle Eastern tox fellows that are come in. And now Dr. Kazi is overseeing that, which is one of our other physicians or medical toxicologists at the Poison Center. He also offers the blast and injury class, the radiation preparedness class, decon, I think decon, Dr. Geller, our medical director is overseeing, and hazmat. So those are our administrative directors and assistants. We have several medical toxicologists. Our fellows actually are on call at the center. There's somebody, there's always two people on call, a first call and a second call. Usually it's a fellow and he has an attending on second call. So if he's unable to answer or he needs a little bit more reinforcement, he has his attending to call. We also have 3 IT managers that are in the Poison Center. They are there for the duration of the day. One is kept on call in the event that one of our systems crash or we start having problems with our phone system or anything that has to do with the IT. We have several. I had a video to show you, but they said that they were unable to pull it up. We have moved to a beautiful center, and we have 7 55-inch screens. We have 3 in the call center. We have 3 set up where the ACD is. And just like the one they had showed earlier, it puts everyone in order who takes the next call. We have walk codes, so if you take a break, you have a code for break. If you're on a consult, you have a code for that. If you are on extended charting, we usually we have a code to follow. We are idle, just like your system, basically. And if you are on one of those codes, you're skipped. We have a, I believe, very sophisticated system. We have CTS2 is the program, the charting program that we use. We have the micromedics, all the basic stuff I think that everyone else has. We also have an education department, health educators. As SPIs, we have two people that are taking care of the education. So they are out there trying to educate our community. As SPIs, we actually go out to the schools. In Halloween events, we usually have Halloween bags, we have pencils. And I personally have gone to my son's school and given them that Halloween talk of the candy, that it's already open, not to eat. But we are out there educating the kids, the mushrooms, what not to touch. I have a little poster back there that I brought that we actually, can you give me one, Sean, please? It actually identifies the pill that looks like a candy. So we try and take those out to the schools and, you know, help teach the kids that not everything is candy. Some things are actually poisonous. So our education group or development is pretty wide and varied in Georgia. We also have contests on Poison Week. We allow all the schools to participate, and they have to do a poster of poisoning. Yeah, you can go ahead and look at it. Sure. There's some back there if you'd like to get some. They actually turn in their posters, and the Poison Center determines who won that, and they get a special recognition, and they go to a dinner, and they get, I think they're put in the paper. So that's a good event for the kids. We also have our new website. It's actually new. On that website, we actually have a link to our senators, our representatives, with the budget cut. We also have a survey, a customer survey for the callers. I'm not sure how many surveys we're doing a month. We get a lot of good feedback. Very rarely do we have that somebody was rude, but we get really good feedback. Then we have the ITP sign up on there. ITP is instructor training program. So we go out to the community again. Sometimes it's group of nurses. Sometimes it's EMTs. And we basically train them to be able to train other groups of how to respond in the event of a toxic emergency. It's a really good program. We give them their supplies. We give them posters. We give them, everything that they can to go out there and educate. So you see them at a lot of the fairs. And then once they're trained, they have a group that they can train. They can train teachers. Anyone that's involved with children that these unfortunate events can occur. And this is the ITP. It's to prepare the community, educators, and leaders to promote poison prevention activities in their communities in an effort to increase the number of Georgians who have the knowledge and skills to prevent and manage poisonings. The objectives is to assess target audiences for poison prevention, identify common poisons. I think in those poisons we talk about plants, the pills that look like candy, just to teach them what could be a potential poisoning. Explain the purpose and the services of the GPC. Unfortunately, a lot of people out there do not know what the poison centers do and the importance of the poison centers in our communities. So that's one of the purposes as well. Determining appropriate response in a poisoning emergency, and plan, implement, and evaluate a poison prevention activity for all age groups. In that instructor training program, we do free training, free poison prevention, free subscriptions, exposures, quarterly newsletters, continuing education for EMTs, nurses, health educators, and invitation to annual awards banquets. So the GPC and other safety organizations can work together by distributing poison prevention materials, discussing proper medication, the usage, the storage. We also get callers with small children that either have an older child or first-time mothers. We usually send out a packet. We'll ask them if they want it, of what things need to be stored, what needs to be put up, what babies can get into, even if we think that they can't. As 15-month-olds are opening the bottles of medication like if it were candy. Attend the GPC instructing training program, participate in poison prevention, and combine the efforts of the media, events, classes, fairs. And this is all to promote safety in our communities. So for more information, Georgia Poison Center, that's our information there. And unfortunately, I had a great video, which we cannot share because it doesn't work on this system. Yes, ma'am?
I have a couple questions.
Yes.
What is the number of calls per FTE? Don't y'all have a very large number of calls per FTE?
I'm sorry, say again?
Your number of calls per FTE?
Per FTE, daily?
No, just like per year, like y'all do like 3,000 calls per FTE or 5,500 calls per FTE?
500. 5,500.
Do y'all still have that treadmill station?
Yes, that was on my video. We have 2 treadmill stations. We have one employee that does not get off the treadmill. She just had a baby, and she's the one that she uses it so much. She's on there, I would say, we do 8-hour shifts. I would say that out of our 8 hours, she's probably up there 6 hours.
How do you rotate?
Not a lot of people use it. I think she's the only one using. No, there's 2 of them, so we have 2 units.
I can answer that.
You
You
can.
rotate a treadmill with your feet.
She's actually great. I really don't even know how she can type because it's so long. If you do, if you do 30 minutes an hour, that's fine. She can type. She doesn't get behind. She's just walking.
65 want to get on it, I never will.
I don't know what the day people do. I really don't know if they are on it. I'm sure that there are a couple people that do it. It only goes 2 miles an hour, which is fine because I guess you wouldn't be able to go any faster. You probably have a syncope on there, trying to type and trying to walk.
I have a question, but,
Sure.
Eileen, but actually, I know we're out of time, but, with your close proximity to the CDC, do you have any special ties besides Sue Gorman to the CDC?
I think we work closely with them, and some of our physicians are at the CDC, but we don't have any close ties. We don't work anything directly with them.
All the fellows that
Rotate through the CDC.
get on board with the program, all the toxicology fellows, RMD and MD, will automatically have a rotation with the CDC. And that includes the international program. So the international fellows who come in to do an observership, they too will get CDC clearance, and we'll have to do some rotation there as well.
Is that primarily an epidemiology rotation or a strictly a tox rotation?
Strictly a tox rotation, and especially with the ASTDR, the tox branch of the CDC.
I know we're out of time, but I did want to mention that we have presently 7 teleworkers, and another 8 are getting prepared to start working at home. And we
The
do,
teleworking system is setting up for those who don't want to telework, will still get a teleworking system. In the event of a crisis where all poison specialists need to come on the phone, they will be able to access laptops or PCs for teleworking or with full access if we need that number.
we also have a center at,
So it's in the same format, doesn't work.
at Grady, at the facility, at the hospital, where they have an emergency room, where in the event, like, for example, I think last year we had a gas leak. So we all had to get out of the building, but they were able to walk into Grady and set up to work. And, we were remotely able to work from another positioning, and some people that got on their systems at home.
I thank everybody for coming. I thank everybody for participating. I'd like to thank my 3 panelists that did an excellent job. Thank you very much, folks.